Very good morning to all of you. I'm really sorry to, have invited, speakers from all over India and seeing the whole audience, and I'm really feeling very guilty about it. So I apologize for that. So, uh, I'm just going to do a brief introduction and overview about the eye problems in development disability. We all know that the pediatric care services in India are not all that good. Most of the time, the problems in the developmental disabilities by the ophthalmologist are neglected, ignored, and often missed out. So, my mission is we have to save vision in children with developmental disability. The aim is to reach out medical, paramedical, teachers, families, and workers and provide a training in use because not everywhere the ophthalmologist would be able to reach by having simple questionnaires to identify cerebral visual impairment using very simple methods for which they can have a very short training and have a network of vision professionals with the visual rehabilitation specialists, ophthalmologists, and of course the optometrists so that we can intervene early and do the rehabilitation. So we all know that the poet says his eye is a window to brain, and eye is no doubt a portal to brain and a window and the tail of the brain. And it's not a surprising statement that the human eye has 2 million working parts and 60% of the human activity is related to brain. And so the visual loss, basically, we all know is brain related and of course eye related. These are the few facts which I'll just run through quickly. 80% of all the learning disabilities occurs in first 12 years of through vision. One third of the children only have eye examination before entering the school. 60% of the students with learning difficulties have undetected eye problems, and only 1 in 4 school age children have vision problems. So our objective is to detect ocular anomaly, record visual capacity, treat visual problems which are neglected, overcome the visual handicap in type, and facilitate overall rehabilitation and development. So the vision disorders are number one in childhood disability. Mentally and disabled children are likely to have the vision problems twice compared to the normal children. So how early are the eye problems detected? Is it intrauterine? Maybe or may not be, I don't know. But the pediatricians detect it at the age of probably 18 months or even earlier. And we as ophthalmologists, when we know that the binocular single vision, fusion, and stereopsis takes place at an early stage, that is less than 3 years, and eye fixation, which is taking place at the age of 3 months, we are detecting this problem very late. And you'll all agree with me that the problem in children and infants is very dynamic and sensitive. So an early detection is very important. So the classifications here is reversible, partially reversible, where we as ophthalmologists can do a lot of work and where it is almost 100% correction. Whereas in irreversible visual rehabilitation, our friends, who are the visual rehabilitation specialists play a very important role. So incidence of visual loss has been recorded, and it's there in the literature by Peter Black, which was a study which was carried out showed that 80% of the children had eye problems in developmental disability, and we carried out a study of 154 children, and we found out that almost 91% of the children had eye problems in developmental disability. So sometimes I wonder how can this be incidental, and is it possible for us to make a difference to the lives of many children and minimize their visual and maximize their visual potential? And one more interesting thing that we noticed is the child with developmental disability had multiple eye problems. So spectacle therapy is one where the child has impaired mobility, impaired communication. Over and above that, the child needs to wear specs due to impaired vision, and we can, by giving simple glasses, improve the vision of the child. Now, the child, would definitely initially there would be a lot of resistance, but once they are comfortable, once they can see the surrounding, especially the mother clearly, they continue wearing the glasses. Accommodation disorders are extremely common in children with developmental disability because the accommodation is not just within the ciliary muscle, it is an automatic reflex within and beyond the eye, and thus reading glasses are important. In general population, when the squint is only 30%, whereas in a child with cerebral palsy, the incidence of squint is very high. not because of the imbalance in the muscle, but because there could be a lesion in the subcortical oculomotor area and the cerebral area. So the treatment options we all know very well. So squint is not always because of the refractive error and muscle imbalance. It could be because of the cortical visual impairment. Now postural abnormalities also can give rise to eye problems. There is a deficient postural control related to retrochiasmatic damage of visual system giving rise to visual dysfunction. Irreversible eye problems, of course, we all know very well, where our low vision friends would help us to, do something about this to these children, cortical visual impairment, and they could help, give a better life to these children. Now, the tree of vision, all of us know very well, a functional map with the roots receiving the messages and the visual pathway which takes us from the trunk to the occipital lobe, the dorsal and the ventral systems, and the clusters of these trees that you are seeing here are visual difficulties, which are the branches of the tree. And the dorsal and the ventral system, of course, we know that the dorsal system helps us to move in space, whereas the ventral system helps us to recognize the objects. And then my future speakers would be, talking about this in a greater detail. This is a child with a cortical visual impairment where there's a fall of vision and the ocular findings are normal, and there's a breakdown in communication between the eyes and the brain. So, I would conclude saying that we as ophthalmologists cannot manage this problem alone. We need it's a multi-centric, disciplinary issue, and all of us in coordination can definitely do something for these children. So, the take-home message is the awareness of visual disability is nil, and these children we need to tackle them at an early age, and see what best we can do. And thank you for your attention. I would now like to call upon Dr. Sudha uh, as a next speaker, and welcome, Dr. Sudha. Yeah. Can you just put up the slide of Dr. Sudha's introduction? Yeah. First CV, please.
Good morning, everybody. At the outset, I want to thank All India Ophthalmic Society for giving us this opportunity to talk about vision assessment in cerebral palsy. No, this is the wrong slide presentation.
Ophthalmologist, and she has Sudha. It's already there. It's there, Sudha. It's there. It's there. Yeah. So she's done her DOMS and DNB from Bangalore Medical College, and she's a consultant at Dr. Rudrappa Hospital, and she has a special interest in cerebral visual impairment. So I would welcome Dr. Sudha to deliver her talk. Yeah.
This one, AOS Kochi.
यही तो आपने ये तो CV है CV है
No, this one. Yes. It is there. Yes, it is there. Thank you. So we will start this session by trying to understand how CVI is defined in literature and how classification affects our patients. So traditionally, we understand CVI as vision loss from damage to retrogeniculate pathways and consider that the anterior visual pathways and the eye is essentially normal. This is a very straightforward diagnosis, and you're defining loss of vision as reduction in acuity and visual field. But we all know that all these children have some amount of concomitant ocular pathology, and it has been well documented in our population by the study conducted by LV Prasad Eye Institute. Internationally, also, how CVI has been defined and the terminologies that were used were studied in this review article by Saki and others. And they recommended that after looking at all the incidents of pathologies reported, that an additional clause has to be added to the definition of CVI, that any degree of ocular or anterior pathway damage present, if it does not explain the degree of visual impairment, then that should also be considered as CVI. So this is very important, because just because a child has CVI, we must not neglect his eye examination. And on the other hand, if there is a ocular pathology, we must not assume that CVI cannot concurrently be present. And in all these cases, identification of function is more important than anatomical diagnosis. So, assessment for CVI is best done by a multidisciplinary team, and all metrics such as clinical examination, visual assessment, and visual behavior assessment has to be done. What assessments are being done now in order to classify and investigate? So, this review article found that all these medical history, examination of behavior, structured history, these were all the techniques which were used to investigate and diagnose CVI all together or in part. Essentially, CVI is a diagnosis of exclusion. Since my other colleagues will be talking about neuroimaging and other things, I would like to go into the history taking and behavior assessment in this talk. A structured history taking is a very important part of CVI assessment and classification. In our country, especially, this is a very simple thing to do because it only needs one person who will spend time to ask the questions. The visual skills inventory by Dr. Gordon Dutton is the in history taking protocol that we have been using. It consists of visual skills inventory for two age groups, 4 to 8 years and over 8 years of age. And it takes into consideration all the aspects of dorsal and ventral stream dysfunction in the visual impairment of these children, and questions are directed at each one of them. So, when you put them all together, you have a very good idea of the child's visual behavior. And if you combine it with other questionnaires such as the strengths and difficulties and social behavior questionnaire, you can get a very good idea of what is this child's quality of life. CVI levels have been defined by different people in different ways. This is a definition which has been used many times by ophthalmologists. But when you tell somebody that their child has 20 by 200 or 6 by 60 level vision or something like that in one eye, both eyes, it really means nothing much to the therapists, the teachers who are handling these children on a day to day basis. So, all people working in the field of developmental delay now would prefer us to use grading based on the international classification of functioning in disability. So, ICF categorization is a much more valuable tool in order to help these children gain the right type of therapy. Even before the ICF criteria came into place, Dr. Christine Roman Lancy had defined the 10 characteristics of CVI, which she used to document by observation, direct examination, and by speaking to parents. So she defined three phases of CVI. Phase 1, only dorsal stream function. Phase 2, there is also a beginning of ventral stream function. And in phase 3, ventral stream function is also getting refined. So with each one of these, there were specified therapeutic modalities, interventions that could be used, and this is a extremely handy way of looking at CVI, especially for low functioning CVI. All people who are used to working with children with disability know about the classification systems based on function, like the gross motor visual functional classification, communication functional classification, etc. We are a little late coming into this for functional classification, but it has now been remedied by Baranello and others who have done a 5-stage classification which is based on the ICF principles of activity participation concepts and not based on pathology. So you have 5 levels of for classification. Level 1 is easy and good use of vision, and in level 5, the child has no vision even in highly adapted environments. So they have defined what purposeful use of vision is, that is to see, recognize, interact, and what compensatory strategies children can use in order to achieve that, either on their own reflexively or if they are taught. So this only defines what is the use of vision in day-to-day activities. It is not an assessment tool, it does not describe etiology, and it also does not, it only describes how the child is performing in best conditions. His actual ability, capacity to improve may be much more than this. We must also understand that in all classifications, whether it is VFCS or any other classification, the levels can change. A child who has seems to have good vision when he is very young may find that he is not keeping up when he goes to a higher class, when visual demands are more. Then he has to copy from the blackboard, he has to take part in games. If he has mild dorsal stream dysfunction, he will not be able to do this. Whereas a child who, if he is taught how to do some adaptation, some compensatory strategies, can move up one level. So these are the limitations of VFCS, and we have to keep on repeating this assessment once in a couple of years at least to understand where we are with this child. So most of the time, classification of disease is done using the international, the ICD code by WHO, and this is also the criteria which is used most of the time for certification for visual impairment for these children. ICD-11 has progressed a little bit in the sense that it does describe disorder of visual cortex and contrast sensitivity and color vision impairments also in the new set which has been released in January 2023. But still, it does not describe visual function. So if we have to tell a school board that this child has got good vision but he cannot copy from the board, they will just look at you and say like, where are you coming from? So many of these children end up being labeled as learning disabled and slow learners. So which means that we have still not defined CVI properly, we have still not classified the disorders, and if we don't do that, the children do not get access to the resources and concessions which are made by governments and school bodies, and it has a huge impact on their opportunities. So a lot of work is still needed to be done in order to classify and explain these impairments to the public at large, and also to make it available as a certification modality. I thank you all for a patient hearing.
Yeah. Yeah, thank you, Sudha, for that excellent, talk, and you have really opened the, Pandora's box, and we were all thinking that this CVI is something, which, uh, which has a very strict, rigid outline, but you have created an awareness, and you have told us so many new, you have given us a knowledge about this. CVI. And if anybody has any questions, you can please feel free to ask.
Thank you, ma'am, for mentioning that CVI is not recognized. It's so terrible that our
Yeah,
children are labeled not only as slow learners, but attention deficit. And
yes,
the reason they don't see, thank you.
yes.
Thank
Hmm.
you so much.
They are not slow learners or learning disabled. They learn in different ways. So that is something that has to be recognized by everybody. They can be made excellent auditory learners. So how we are going to get this into the minds of certifying. See, once you get a label, a certificate to say you're learning disabled, that stays with you throughout your life. So they don't get admission in some schools and colleges, and job opportunities become restricted. So we need to change classifications and definitions.
And I think all their life, they live with that social stigma also. Acceptance in the community also becomes very difficult, and they have to live with the complex all their life. Yeah, I would like to invite our next speaker, Dr. Pooja. Yeah. Dr. Pooja is Sarbajna is a consultant optometrist and a vision behavior therapist in one of the prime institute of the country, that's Narayan Netralaya. And she is a PhD scholar from Massachusetts University, Netherlands, and a master trainer, RBSK. So without wasting much time, I welcome you, Dr. Pooja, for your talk.
Thank you, ma'am, for such a nice introduction. And good morning, all. Thank you for calling me here, and thank you to give me this opportunity. So, without further delay, I want to start. My topic is functional vision assessment on CVI. So what is visual function and what is functional vision? So already, as history part is already done, that is the main thing what we check for functional vision. And visual function means the visual acuity, color vision, visual field, and contrast sensitivity. And we visual function we check uniocularly, and functional vision, how the child is doing the binocularly we do functional vision assessment, and how does the child perform their daily living activities, that is functional vision. So in visual function, visual acuity, majorly we checked with LIA paddle, and then we introduced LIA distance vision chart and LIA near vision charts. So how we perform LIA paddle? So basically LIA paddle, there will be grating acuities. It starts with 4 paddle. It starts from 0.25 and it goes to 8.0. So we have to hide with a gray background, and we have to show the child that the child is focusing on the black and white line or not. And then slowly we have to start from 0.25, 0.5, like this slowly we have to take it down. If the child can respond to LIA paddle 8.0, we will give them a visual acuity chart of LIA symbol chart. That is, we consider with 4 shapes: apples, house, circle, and square. And we'll tell the mother to train them on that 4 shapes, and we will try to start their LIA distance vision chart. So basically how we do that, we use this light illumination box. This light illumination box is designed in three different amplitudes, and the vision charts also designed in 100% contrast, 50% contrast, 25% contrast, and 1.25 and 2.5. So this is 100% contrast. So what we have to do, basically we have to show the child one shape, and the child needs to point it on the chart. And we have to introduce near visual acuity chart. This is also LIA chart. Basically we need to point one chart, and we need to measure 40 centimeter distance. This 40 centimeter distance measurement is very important, and we have to point one, and we need to tell the child to search from the down which one is on the same one. So ideally in CVI cases, what we do, we start to assess from 4 months, we start to do LIA paddle. We can do lesser age also. We doesn't do TAC in CVI because the teles acuity require a proper the control. Child needs to sit in a proper position and all that. But LIA paddle can be done in a lying down position also. Any position LIA paddle can be done. But we try to maintain 27 to 38 centimeter distance to do LIA paddle. Contrast sensitivity, we use hiding Heidi. I don't know other videos. Hiding Heidi basically. So hiding Heidi is again it's a smiley face test. So hiding Heidi starts from 100% and it goes to 1.25%. So basically we are going to hide one face and we are going to take it out, and we have to see the child respond. Child is responding to the face or not, and we have to document that contrast sensitivity. So we get lot of kids comes with us with a complaint of not looking at mother face. That is the major complaint we get from every second day, that the child is not looking at mother face. When we do the contrast, maybe the vision is coming around 4.0 CPCM, that is quite good. But when we will do the assessment, we'll found the contrast sensitivity is very less. So already Leah ma'am's literature review shows that if the child is not responding in hiding 5% of contrast, then the child will not have eye contact. So we have to measure and we have to document. When the child is reaching to 5% of the contrast in hiding ID, definitely the child will have eye contact. One and second one, when we are documenting either Leah paddle, either hiding ID, we need to document the distance. That is very important. Because lot of time in our clinic, we find the problem that mother will tell that every time the visual acuity, the Leah paddle or the contrast sensitivity is coming on the same thing, like 5%, next 3 visit. But what we show them is first time the child is responding in 5 centimeter distance. See, next time it is in 15 centimeter distance. So we are increasing the distance. Maybe the plate is same, but the distance is increasing. So like that way also we can counsel the parents. Now next is visual field test. This is very functionally and this is very easy to do also. We use regularly Leah Wang to assess the visual fields. So basically here 2 person is sitting, one who is going to show the light and other person opposite side who is going to observe that how the child is focusing on that. So basically from back side the child should not see the person hands, so then they will give that response to the movement. So basically the front side which optometrist or whoever is sitting, they are going to see the child's eye movement, and back side who is sitting, they are going to show the light in different gazes. Like this we do visual field. If we doesn't have Leah Wang with us, what we do, we hold a black card up, in front of us and we have to show a familiar toy to the child in different direction and we try to see the child is focusing or not, and we document the visual field on that. Next is functional vision, dorsal stream function. How we check dorsal stream? You can see here, I had placed lot of ducks, and with this duck, I had placed one teddy bear in center of that. And I asked the child that among this all duck, can you find the teddy bear? He found. Then I made it complicated and I put the same color one hen. And I am telling the child to pick up the hen. Now the child is confused, so he is taking lot of time to pick up the hen. He picked up a wrong one. So again, I am trying to motivate the child to pick up, but the child is not. So what I did, I tried to remove lot of other clues and I tried to make it more easy. And now you can see the child is picked up easily. So this is how the problem the child face in school, as Sudha ma'am already explained that lot of people in school, they will have 6/6 and 6 vision but not able to copy from board. This is the complaint what the child is having. The child can't see the crowding in the board and we are telling learning disability and all that. So if we can make the crowding little less, maybe that will be helpful for the child. This helps in our other assessment also, other therapies also, like occupational therapists and all. When they will do multiple things on a same place, it's difficult for identifying. When it's one at a time, it's easy. Now next is Leah mailbox. It's just for direction. Where we are moving, the child needs to place sent on that. Now next is ventral stream function. This is first is size recognition. So basically this is Leah rectangle. We need to place all the Leah rectangle shapes and we need to ask the child to match with the same shape. Here it's Leah emotional card. Emotional card is basically to train the child's brain, all the emotions of the mother and other people. So there are emotional cards. We have to place all the cards and we have to ask the child to match with other. This is Leah puzzle. Leah puzzle is for color and contrast. So basically there are 4 shapes. So we train the child how to match the colors and the contrast. Now the visual characteristic in CVI, mainly there will be 10 characteristics. One is color preference, need of movements, visual latency, visual field preference, difficulty with visual complexity, need for lights, difficulty in distance viewing, atypical visual reflex, difficulty with visual novelty, absence of visual guidant reach. The characteristics with dorsal stream, that is where stream and what stream. Basically dorsal stream is where stream and ventral stream is what stream. So basically these streams, the characteristics will be there in dorsal stream, color preference, and ventral stream also it will be there. Need of movement, it will be more in dorsal stream, ventral stream it will be lesser. And visual latency will be not present in both. Visual field preference will be more in dorsal stream, and in ventral stream mainly they will have visual complexity. Like that, absence of visual guidance or reach will be present in both. Now I will just go through a case, because every day we will see this kind of cases. This is a 11-month-old male child. First seen in pediatric department. The complaint every day we are getting not looking at mother's face, not able to reach the object, visual acuity not fixing and following light. There is a nystagmus anterior segment within normal limit, posterior segment mild global pallor. Again, say the major complaint of the mother is eye contact is not there. Minax is absent. The child doesn't have any independent movement. Prematurity, birth weight 1.4, NICU for 20 days. We are seeing every day in our clinics MRI, HI. So in assessment, what we did, we found in for each and every CVI child, we do dynamic retinoscopy to find how much is the lag. Without giving lag glasses, there is no point of checking vision or contrast or whatever. So we did the assessment and we found that the vision with Lia paddle was with or without glasses, the child is not responding. The hiding Heidi was also not responding. And Lia went, the child is not responding to any gauge. What management we had done, we had given glasses, we had started a vision therapy for 1 month, and we had asked them to do physio consultation. The line of treatment was giving glasses, and to improve their near vision, we started a vision therapy and light stimulation exercises. So in light stimulation exercises, we started off light box stimulation exercises and light ball. Basically, what we try to do on this therapies is, you can see we are trying to give the tactile clue to the child, because we feel that if we are showing the lights and the child is not responding because the child can see the light. So we try to give them the tactile clue that the retinal calcarine pathway will stimulate the tactopapinal pathway. Automatically, the child will start off seeing the lights. And we do a lot of light box activities. We do all the puzzle games and all top of the light box. This is a mirror therapy. Basically what we try to make the child down to the mirror with the light box, and we put lot of bindis on that top of the mirror, and we try to attract the child to focus on the mirror. This is the facial communication. We try to enhance the face of optometrist, and the optometrist is trying to attract the child towards her to get their attraction to the eyes. After 6 to 8 months of vision therapy, we did the Lia paddle test. Lia paddle is showing 1.0 CPCM. The social interaction was developed, the eye contact was good, and the hiding height is showing 25%. And the child has started off responding to the all gauge of visual field. Then we introduced, in between we introduced Lia, all the, whatever therapies we are doing all the puzzle exercises and all, top of the light box. And then again we continued the management with the glasses and the vision therapy. We shifted them to home based, and we advised them to go for physio and occupational therapy. And then later on we had introduced the vision therapy software, that is Sinus Visual Integrator. So how we do is we try to hold the child, and we first train the child how to do that, and the child will start off doing the same. And then we will give them the daily living activities, so like brushing, milk bottle, food and drinking, reduced cluster and all that. So what we do every routine day is how we tell them to design the milk bottle. We'll tell them to take the milk bottle and put different kind of tapes on the milk bottle and hold the torchlight top of the milk bottle, that the milk bottle will give a reflection, and the child will get interested to hold the milk bottle and get feeding. Even in with brushing also, put a different color toothpaste and hold a torch top of that the child will get interest to do brushing. Then food, if you're using a black color plate, try to use like apple kind of fruits and all that, and don't give too much of fruits at a time, give at one at a time, so the child will get interest to have it. Again, dressing training, wearing shoes, socks, toilet training and mobility trainings. And this is the paper what we prefer to, in our practice we do every day, and we use these techniques of therapy. This paper is by Dr. Rajvardhan Azad, and we do all these therapies, and we follow this protocol only to treat with a child with cortical visual impairment. And this is the last one. What I want to say, that this is a software developed by Narayan Netralaya. This is called Vision Nova. Vision Nova is a software which helps the child with cortical visual impairment. It is designed in an order that the child can take the software to home. They can sit and do it at home, and the results will automatically come to us. Thank you. Any questions?
Pooja, that was an excellent presentation. With so many videos, we could really, understand what you are
Thank you, ma'am.
explaining to us. What's the cost of this software Vision Nova? Any?
Vision Nova, as of now, we are giving it in free of cost to the poor kids. But later on, when it will come to market, it will cost around 18,000. This can be displayed as a SVI. It's almost similar to the through SVI. SVI, so it's very expensive. So government hospitals and all can't purchase. But this is only 18,000 with all the if the person is having hardware and all that, nothing from our side. We will just give the software.
Thank you. Any questions from any of the audience? Thank you, Pooja. Yeah, yeah, please. I would like to now invite Professor Aditya Goyal. I think he doesn't need any introduction, and without wasting much of the time, I've just put up a slide about all his achievements and all his qualifications and present positions. And presently, he is at Sankara College of Optometry as a principal, mentor, adjunct faculty, Philadelphia, member of MOHFA, FW, and is president of Association of School and Optometry, College of Optometry, India. Over to Professor Aditya Goyal.
Thank you so much, Dr. Shari. Good morning, everyone. Very interesting and a very different experience to be speaking to so many audience today. But then, all the same, it's very interesting. I'll be talking a bit about practical tips in vision therapy. In fact, Pooja has done most of it for me, so she's made my job a lot easier. I'm practically going to repeat most of the things that she mentioned. First thing to begin with, we all call it CVI, or cerebral visual impairment or cortical visual impairment. But I think we need to differentiate between CVI and DVM because the prognostics are very different between the two. In CVI, the prognosis is not that great, but DVM prognosis is very, very good. So we should look at delayed visual maturation and differentiate it from cortical visual impairment. And pupils narrate all the story. You look at the pupils, and from that you can make out whether it is CVI or DVM and how the prognosis is going to be. First thing we need to remember, move from ability to inability. Do not start working on the things that the child cannot do. There's no way in which, whether it is vision therapy or anything, I think the first thing we should work from is what the person is able to do and then go over to the things that he's unable to do and do not jump it. Protocol that should be followed depend upon the visual abilities that the child has. So like Pooja mentioned, you have to measure all the abilities, whether it is the visual acuities or the contrast sensitivity, eye movements, etc., etc. And then depending upon where the child is, start proceeding from there. Now, most important thing, the person who the child relates to maximum, the baby relates to maximum is the mother. The therapy ideally should start from mother. We as optometrists or therapists or whatever, we may give adjunct therapies, but the most important therapy is provided by the mother. So we always tell the mother to hold the baby like this, wear very bright clothes, have a big bright bindi, and keep talking to the child, because that becomes a very important thing, because the child is used to the mother, child is used to the mother's touch, child is used to the mother's voice and language. So ask the mother to speak to the child as much as possible, looking straight into the eyes. The baby may not be responding, the baby may not respond at all, but that is most important. Now, from our perspective, if there's no perception or very poor perception of light and no fixation, follow the steps ahead. Or if there's perception of light, if there's fixation, then take from where we go now. So the first one, like Pooja mentioned about the light stimulation. Caution over here, sometimes when the child has seizure disorder, please do not use flashlights, though a few neurologists say that it's okay to use flashlight and they will manage the seizure. But then I would have it as a word of caution and not to introduce flashing lights because they are contraindicated. It may induce seizure disorder. Use LED lights, light emitting toys, etc., and continue until there's some semblance of perception of light and there's some amount of fixation. Again, keep a watch on the pupils. We use this floor rotator considerably. So what we do is we fix light on that, a torch light or a small LED light, and rotate it at a very, very slow speed. Keep it in a dark hall, dark room, and rotate the floor rotator at a very low speed, and the child needs to follow that. So the brightness of the light could be increased or decreased depending upon the perception, depending upon the fixation. And if the fixation is not good, stop it. Keep it stationary till the time the child starts fixating and then start rotating it again. The next we work on is the light emitting toys. So you'd seen a video when Pooja was presenting. So make sure there's no sound in the toys, because the child may get attracted by the sound and then look at the toy or follow the toy because of the sound. Please do not have the toy making any sound, have only the light. Move them very slowly in front of the child because the child is able to perceive the movement, and if it is too fast he may not be able to perceive it. So move the toy very, very slowly and see that the child is maintaining the fixation. If the fixation is lost, go back to the primary position and start moving it again. Introduce patterns. So we have plenty of patterns like that. It could be in form of paper patterns printed on paper. It could also be made as a PowerPoint presentation or some kind of software, and that can be presented to the child. And again, look for the fixation, and once the fixation improves, make the pattern as intricate as possible, because initially it is large, huge patterns, and as the fixation and the perception improves, keep on making it as intricate as possible. So I have made a small, the bold one and a slightly intricate one besides that. Once the black and white patterns are perceived, introduce colors. I like to put the red and the blue or the red and the green because these are two different parts on the different areas of the spectrum. So that is the reason why we introduce the red and green or red and blue. And you could also introduce filters, the red and blue filters, which make the perception of color as well as perception of the objects possible. Look for the fixation with each eye and continue until constant fixation is achieved. Then we use the rotator like that. So as you can see, it has white, green, and red objects made in that. So you could use anaglyphs, that is a red and a blue glasses or red and green glasses, and then track the eyes. We like to use a lot of mobiles, so we use slow moving videos. Fixation is definite at this point of time. Introduce very slow movement of the video. Take a mobile or maybe on a tablet, move it very, very slowly across the visual field of the child and see that the child is able to follow that. Once the child is able to follow in a linear manner, start rotatory motions. And once the child is able to do that and maintain gaze, maintain fixation, then a zigzag movement and other movements and the faster movements can be introduced. Introduce big toys with no light and encourage them to reach out to the toys. Initially, we are only looking at the fixation, the eyes, whether the child is able to perceive it, look at it or not. Once all that is there, start reaching out. The eye-hand coordination has to improve. As the child is able to see the big toys, please reduce the size of the toys and keep on going till the time the child is able to look at the smallest possible toy and able to fixate it and follow it. Introduce movements and look for accuracy of fixation, maintenance of fixation, and accuracy of reach. The child should be able to reach out perfectly well and hold the toy. As the movements improve, keep on making it intricate, and the child should be able to fixate and reach out accurately. Like Pooja mentioned, you could introduce softwares like Senate Vision Integrator, Prime, etc. Lots of softwares are available in the market today. The speed of the rotation can be changed. They all come with touch screen, so the child is encouraged to touch the object and see it vanish. So it's a big game for them, and the size of the rotating dots, rotating objects, rotating alphabets, all that can be introduced over here, including contrast and color. Once that all is achieved, start working on binocularity, because that is one very important thing that we work on. Stereo, depth, binocularity, that is the ultimate thing that we work on and work for. Look for tropia if the child has a tropia. Introduce binasal patch to initiate peripheral fusion. It's a wrong perception that the binasal patch is going to push the eye out and it can be used only in esotropia. It's not so. It is to induce peripheral fusion and not to push the eye out or in. These kids have very centralized viewing, and that has to become more peripheral because that is most important in binocularity. Introduce translucent patches in case of tropia. I am for one against total occlusion where you put an opaque patch. I would like to use Bangetta foils and translucent occlusion, like the case, like the child over here. A good objective refraction is required and prescribed glasses in case of significant errors. And they can be prescribed binasal patches to encourage peripheral fusion and binocularity. And that needs to continue till the time you're perfect with it. And invariably, we do not reach these levels in case of cortical visual impairment, but delayed visual maturation, absolutely yes. So thank you so much for your attention. We'll be happy to take questions.
Thank you so much,
Thank you,
Professor, for your wonderful talk. Now, one question that I have is how, when you are having a child with a CVI, when do you reassess the child? And supposing it's a very gross CVI, when do you reassess the child after the whatever best therapy that you have given?
Sorry, can you repeat the question?
No. For example, you have a child with a severe CVI, cortical visual impairment, and you have given the best therapy. Okay. And when do you reassess the child? I mean, whether the therapy is, working well, or how frequently you do the reassessment? Is it on a daily basis or monthly basis?
We like to reassess the child on a frequent basis, but then the therapist knows exactly where the stage is, and based on that, we continue. So, ideally speaking, I would like to reassess every 2 months or so, but then, in case the child is not improving at all, then probably more earlier. And if the child is improving more, then again we make it more frequent.
And when do you, feel that the child should be referred to the ophthalmologist? When do you think that the child should be referred to the ophthalmologist? How frequently will the ophthalmologist intervene? Maybe
Difficult
once.
question to answer that, but then uh, see, it's a kind of inter-professional relationship, and I personally, for one, do not believe in doing vision therapy alone. We work along with other therapists, for example, physical therapists, occupational therapists, speech therapists, especially. We like to work along and perform the therapies together rather than do it solo. So that I felt, and what I feel is in our clinic, we have the physical therapists, we have the occupational therapists, we have the speech therapists who are working along at the same time on the child. That brings much better results as compared to
Yes.
solo therapists working.
Yes. Yes. Thank you very much. Thank you.
Thank you, ma'am.
Yeah.
Doctor,
Yeah.
is there any specific this thing that you do for optic ataxia, where vision by itself may not be a problem, and is there any particular therapy that we can do for that? And Usha, I think ophthalmologist should see the child if the child is not improving.
That's what I
That's all.
wanted to understand
The
from
routine checkup
Professor.
once a year, if there may be enough.
I think
But
that may not be
if the
enough.
child is not improving,
Yes.
then
Yes.
both the neurological as well as reevaluation of ocular status and all that also has to be
Yes. Yes.
reviewed,
Yes.
because there may be something else which is preventing.
Right.
And of course, if you have to give prognosis to the parent, then it becomes important.
And then the
See,
best place.
unfortunately, ma'am, most of the ophthalmologists do not understand the difference between
Exactly.
eyesight and vision.
Yes, that's exactly the reason we are here.
That is very true.
Yeah, and that's the
One more
reason we are
point
here.
on this, that we at Narayan Nethralaya, what we do is we first it goes to ophthalmologist only, and then it comes to us, or sometimes it comes to us and we will send it for opthal opinion, because mainly our CVA is checked by Dr. Anand Vinayakar, pediatric retina. He performs specifically a OCT scan, and in this OCT scan he shows the CVI marker in OCT, and every 3 months when he is repeating the CVI markers for OCT, and he's showing exactly the layers are developing. So that's how we do.
Yeah, I think that's an excellent way of doing it, and that's the reason why we should have an.
Another thing very unfortunate is whenever there's a visual, the eyesight is low, optic disc always seems to be pale, which actually not the reason.
Right.
We are not able to differentiate, we are not able to find out, and we just mention optic dispaler or optic atrophy where it need not be the case. We discount the neuroplasticity, we discount the possibilities that can always be there, and we send the child to a blind school, and that's the end of it.
That's true. Yeah, it's an unfortunate thing.
Sir, I have a question regarding the toys which you have mentioned that sound should not be there.
Yeah.
Sorry?
Regarding the bright toys in which sound should not be there, you have mentioned, right? So, wouldn't an audio visual feedback loop present in our brain help in kids for developing visual maturation
Yeah,
faster?
see, in case it is leading to some perception, yes. But what I had introduced was, what I had told was the time when the child has started perceiving. At that time, I'm not concerned about the auditory feedback.
Yeah, yeah.
I'm more concerned about the visual
Yeah.
feedback.
So, can we initiate with that, then remove that
Yes,
audio
yes,
cues?
yes,
We can do that, right?
Yeah.
Thank you.
Thank you.
Yeah. So yeah, that's it. Yeah. So thank you, Professor Aditya Goyal. And I think for this kind of work that we want to do or we are interested in doing, we must have an institutional setup, where all the specialists are there under one branch. Hmm. Yeah, yeah. I think our next, meeting we should come out with something like that. So our next speaker is Dr. Madhumati Bose. She has an extensive.
Ma'am, I'm not a doctor. I'm just Madhumati.
I'm sorry for that, but I think on this platform, I think I'm sorry for that. And she has 30 years of professional experience in this field, and she's attached to Holy Family Hospital, and also to she's a consultant at AIMS, where she helps in running high risk clinic, and she's a certified in nomoscale diagnostic based treatment, and of course she's a brilliant speaker, and she's at an international level trainer and has conducted several workshops in India and abroad. So over to uh, Madam Madhumati Bose.
Thank you. Thank you, ma'am. And it's an honor to be here and be part of the team. Thanks. So my topic is visual therapy with multisensory input. Let's start. Next, please. I'd like to start by thanking all the parents, the children, the doctors, the support staff of all the hospitals that I work in, because without them, this presentation won't have been possible. Next, please. I know it's multisensory that I have to talk about, but ma'am, I seize this opportunity to talk about visual protection and stimulation in the NICU, because visual stimulation is becoming a buzzword these days, and at times I think it's very unnecessary, especially for the NICU. Next, please. So we all know there's been a lot of advance in medical science, and the survival rate of our preterm infants, sick infants, low birth weight, small for gestational age have all increased. Next, please. But unfortunately, the environment in the NICU is not conducive for sensory integration or brain development. The environment in the NICU is very toxic. There is not only sound, there is touch, there is smell, and of course, so much of light. Next, please. Next, please. In the womb, what happens is the level of, our senses, they come in a sequential manner. They develop in a sequential manner. And here in the NICU, they are bombarded all together. So in the NICU, protection is more important. Please remember, more important than stimulation. If we have to give stimulation, it has to be age appropriate. Next, please. All our babies, especially the ones below 32 week babies, their pulmonary reflexes, the pupillary reflexes are not developed, and this interferes with their development. The intensity and the level of stimulation affects visual acuity, development of color, development of the eyeball, and the retinal development. If we have to give stimulation, the best stimulation is at least give them first protection and then stimulation. Protective lighting has been recognized in developmental supportive care. We have to give cycled lighting where there is 12 hours of daylight and 12 hours of night. So this, they have shown that children, the infants are less fussy, they cry less, they are less disturbed, the level of cortisol is reduced, this stimulates the growth hormones, and it has better sleep, and the circadian rhythm follows. Next, please. So if we have to give stimulation, it's only after 33 to 36 weeks when the children start opening their eyes. Let them see their mother's face. Before that, keep them away from direct sunlight, away from the windows, and away from overhead lights. It's only the term babies, the 40 weekers, that we start giving them patterns. I visited AIMS Jodhpur recently, and I saw that it was brilliantly planned, the NICU, where they believed in the daylight, the cycled light system, and the windows were away from there, so they were getting the light at the same time. It wasn't directly overhead. Next, please. It's not only the lights that our infants face; it's also the position. All of our infants in the NICU either have their head extended or to one side, or they're looking at the window. This affects the vision and the position of the head. Next, please. Can you see this incorrect positioning of the NICU of the baby and 5 months later? So obviously the peripheral field at one side is going to be better than it'll be more exposed to the other side. Next, please. Second part, multisensory input for holistic development. Next, please. Vision, we know, affects each and every area of our development. So then next please, why do we restrict our vision therapy only to 9 to 10 in the morning or 10 to 12 in the afternoon? It has to be throughout, especially for infants. that whether it's seeing the mother's shiny clothes, or to reaching for food, or even in any kind of position for our children with MDVI, just give them the stimulation each and every moment of the day. Next, please. Vision therapy is not simply torch. Yes, it begins, but it has to move away from there. Next, please. And thank you, Dr. Aditya, for mentioning about the flashing lights. And I know this is going to be recorded. Lights like this, as well as sounds, if the audio can be put, they are terrible. They are not therapeutic for the child at all. In fact, they lead to seizures. Okay, next, please. Vision stimulation. Whenever we give vision stimulation, just remember it has to lead to visual learning. It has to be meaningful, enjoyable, and functional. Can we see the video? I'm using sound here. This is your question that you asked, sir, at the back, because that's meaningful for the child. But I am not testing yet. I'm just getting the attention. So there was no sound now. That's when I was testing. Adapting the environment is important. Without adaptation, no stimulation is complete. Next, please. Next. Simple adaptation. This is a child from the NICU. First video. The child's looking up, extended head, hands are not coming into midline. Next, please. Position, inclined position. You have a toy stand in front, and you hold the legs, and the hands will come automatically in front.
Put a ball here also, which he'll try to now. Now do you see his hand, the way it's coming now?
Another thing, our children hate touching textures. They are picky eaters and they don't touch. So for us, vision therapy includes giving them textural experiences also. So it's the orange that they eat, instead of putting in the mouth, let them peel, let them put it in the mouth, let them feel the segments. Next, please. Vision and auditory, again, your question. And this includes motor planning. He's seen the piano, but I want him to extend his hand to touch it.
Touch piano. Okay. कहाँ है piano? देखो piano कहाँ है?
It's the processing. We have to give them time to process.
Okay. अब piano कहाँ गया?
Thanks. Okay. Next, please. Play is the best way of integrating the senses and giving them multimedia experience.
More right and left. Huh? Okay.
So this is communication, this is balance, and this is vision altogether. So this is Mishti. She is a reader in class. She's a writer-reader. But I want to show you that when it comes to everyday life, that motor planning of hurdles, how that interferes. This is our challenge with our children with CVI. You know, they are so good at certain things. And the teachers, and thank you for saying it earlier, Dr. Sudha, that the teachers, unfortunately, they don't get an idea about our children. Ye to pad sakti hai, but what about when it comes to crossing?
टच करके जा रहे हो मेरे पैर को ओके चलो
Generalization. Just because they can recognize a ball in one place does not mean that they can recognize a ball in another situation. And to make it from simple, like you said, Dr. Aditya, to simple to complex is what works for our children. Don't show the videos, it's okay. Therapy in different settings. It's not only the room setting. We have to take them outside, because after all, they can't just be in a classroom or in their house. So give them experiences outside. That gives a holistic. Please see this. Sometimes we don't want to leave it till last. That जब बड़ा होगा तब वो कर सकता है. How to hold a cup, how to pour.
अब चलो handles. Very nice. Very nice. Very nice. Okay.
Danga? Hello, Danga?
हाँ वेरी गुड. काउंट करके काउंट. ठीक है, सही है, सही है, सही है. करो. 1
2, 3, 4, 5.
स्टॉप. सही तरीके से रख.
Our children learn. Don't write our children off. You let them practice. They will accomplish and they will learn the task.
प्लेट भी तो देना है ना मुझे. कप और प्लेट दोनों एक साथ.
These are little things which we as parents, as teachers, we do for the child. But in the long run, it doesn't work. They need to do it themselves.
गिरने वाला था. कुछ नहीं होता. मेरा हाथ यहाँ है. देखकर मेरे हाथ में दे.
बच गया मेरे कप से.
हाँ बच गया. मेरा हाथ कहाँ है?
Next. This is Nehal's story. She comes from Kashmir and she's progressed so much. But I want to tell you later what happens. Just see this. This is
सुनो. लेज चाहिए. लेज.
She could differentiate between Lay's and Uncle Chips, which I don't think I can till now.
बहुत सारी चीजें हैं यहाँ. लेज देख लो अच्छी तरह. लेज. चलो एक एक करके.
और फुल बॉक्स देखो कहाँ.
ओनली रसभरी. हाँ.
So there are times she's not looking, but that's okay. You can't expect her to look 100 out of 100 times.
वेरी नाइस. कहाँ है हैंड? कहाँ है कमला दीदी की हैंड? कहाँ है? देखो रसभरी कौन सी है?
यस गुड. अच्छा रोजबेरी.
रस.
We gave her experience of peeling the coconut husk, everything, touching finer things. She wanted to explore our campus. And she wanted to climb a tree. This is vision therapy for me. But unfortunately, she got one seizure and she's lost everything. Next, please. One of the main things about therapy for infants, for children, is early intervention and parent support. Unless we support parents, no therapy will work at all. They're torn, they're running from one place to another. Next, please. Home visits is very important part of our visual therapy. Thank you to our parents and our children. Without you, we are nothing. Thank you. And thank you. And I'm sorry I took away extra time. Thank you.
Thank you, Madhumati, for that excellent talk. You got out a very important point, and I think we'll all agree that the mother is the first teacher for the child. The mother is the first teacher. The mother is, there round the clock, and it's so important to have, small hints and train the mother so that the therapy is, are they taken care at home also and in the clinic also as and when required. It's a very important point that you got out. And another thing I wanted to know from you is the NICUs, whether you showed different postures, where the child should get the right, posture. Is it in coordination with the pediatric neonatologist that you're working with? I mean, because there are some positions which the pediatrician and the neonatologist may or may not
agree. Yeah, I agree that there are certain positions that the child has to take, but because of that, if at least after the situation is under control, if we can change the posture and just not change the posture because the child needs, and not just let it be as it is. So we do need to give that input, at least make the doctors, nurses aware, because we are getting children in the high risk clinic where if they are faced this side, usually they are on the right side, so the right temporal and the left temporal is okay and the right, but here the left peripheral is not just working at all, so that's the reason.
do you have a standard format or some structure which could be put up in the major units of the NICU in the country?
Yes, AIMS has done this thing, 7-part video on developmental supportive care. This is part of developmental supportive care. And what are the stress signs? How do you change the position? It is there. It's
Yeah.
and I don't know how much it's been following everywhere. So
I think it will be a very good, idea to have it in all the NICUs in the country.
it would really help if developmental supportive
Yes.
care can take over. Thank you.
Thank you. Any questions from the audience? Yeah. So we have our next speaker, Dr. Rishikesh Mai, who is a director of Avadut Netralaya from Nagpur. And his areas of interest is, of course, visual rehabilitation in children with special needs and strabismus myopia. And he's received several awards. So without wasting much time, I would request Dr. Rishikesh to proceed with his deliver his talk.
Thank you, ma'am. Thank you, Dr. Usha, ma'am, Dr. Sudha, ma'am, and IACP for making me a part of this important instruction course on cerebrovisual impairment. Uh, I mean, most of the part has been covered, except for the neurological basis and MRI findings. So, cerebrovisual impairment or CVI is also called corticovisual impairment, but it involves also the subcortical parts as well. So it's an most common, or it is an important or frequent cause of visual impairment in children in the visual world, in the developed world, but also in India. Delayed visual maturation and CVI, I think that part was covered by Dr. Aditya sir. So let us move on. So the older term for CVI was cerebral blindness, but actually because of the neuroplasticity, the patient usually doesn't have blindness, and some amount of visual vision the patient usually gains. There have been revamped perinatal services in India, because of which CVI is an important cause of bilateral visual impairment in children even in India. So the causes of visual impairment, most common is hypoxic ischemic encephalopathy. There can also be a structural abnormality in the brain or cerebrovascular accident. The most common neurological association is delayed development and seizures. So coming to the neurological basis, we start with eye, which acts as a sensory organ, where the light impulse is, I mean the light is converted into an electrical impulse and then passed into the anterior visual pathway, which also includes the optic nerve, the chiasma, and also the retrochiasmal part till the lateral geniculate body. Usually in CVI, this part is normal, so that's why you get a normal uh, ophthalmic examination. Then comes the posterior visual pathway, also called the geniculocarcarine tract, which or the optic radiation, from where the axons pass from the geniculate body all the way to the visual area and the visual association area. If there is involvement only at the optic radiation, the patient might have a visual field changes, and I mean even in children doing a confrontation visual field can be possible in order to get to know whether the patient has a hemianopic or a quadrantanopic defect. From there, the stimulus passes to the visual cortex and the association areas, and then it also has an integration with the other stimuli or other parts of the brain, especially the hearing and touch. Uh, and then there is integration into the motor cortex, based upon which we have the characteristic visual behavior. So any problem anywhere here there will be change in the characteristic visual behavior in the patient with CVI. The causes include infantile, the most common is a perinatal hypoxia, and in the acquired type, it can be because of respiratory arrest, a head injury in the early perinatal period. So the visual characteristics, this part has already been covered. More important, that the patient might have visual field defects and he might have preference for light. As has been mentioned, when you are checking, don't use minimal sound or no sound, more of light. Now coming to the MRI findings of children with CVI, the most important is the periventricular leukomalacia. Uh, Leuco is white matter, malacia is loss. So basically the lateral ventricle, the part of the lateral ventricle in the trigone, that is the part from where the optic radiations pass, and usually this part gets affected. There can MRI, according to literature, MRI does have a visual, can predict, it has a prognostic value to predict the good visual outcome. So if there are no or minimal MRI findings, it suggests that probably the visual outcome in these cases might be good. So I'll share a couple of cases with the clinical findings. This is one of the patient who presented to me. This is the sagittal section T1 weighted image. You can see the corpus callosum is the part which I wanted you to have a look. This is the anterior part and this is the posterior part and the splenium. Here the corpus callosum is normal. Usually the splenium is the part from where there is the integrating fibers from the two cortices, especially the occipital and temporal part, they pass through this. So if this splenium is normal, the same patient, the T2 weighted image didn't show, or a few patches of hypoxic damage were seen in the occipital cortex. The clinical finding of the same patient, depending upon his mood, we have to do a visual testing, but it's basically seen that he doesn't have any a gross nystagmoid movement. He is able to follow the object. He is not trying to look up or search for the source of light. So probably the visual outcome in this case is good. So another patient, now look at the sagittal section of the T1 weighted image. You can see that the splenium is, there is a loss or volume loss in the splenium here. And the same patient, this is a flare sequence which shows that there is a reduction in the size of the optic radiations, this part, which is close to the occipital cortex. I have been following this child for 4 to 5 years now, and there has not been any significant improvement in her visual behavior. She has nystagmoid movement, and instead of following the object, she tries to constantly look up, that is towards the source of light. So the MRI findings and the visual outcome, they definitely indicate something. So coming to a few more cases, there can be, whenever there is a loss of the white matter in the periventricular part, there can also be ventriculomegaly. That space will be filled with the ventricle and CSF, or the ventriculomegaly can also be seen in T2 weighted image. Important part is the peritrigone. The trigone is the posterior part of the lateral ventricles from where the optic radiations they usually pass. So you can see that there is damage to the optic radiations, which definitely indicates either visual uh, uh, field defect or the reduction in the visual acuity of these patients. So MRI findings have been found not to have any gestational age. So even in a premature child can have a normal MRI finding, whereas a full-term normal delivery child can have significant MRI loss. So loss of the peritrigonal white matter indicates loss of the optic radiation. Usually complete loss of vision is not there because of the neuroplasticity. The pattern of MRI the most important is periventricular leukomalacia, which indicates a poor visual outcome. But sometimes there are minor changes in MRI which indicates a good visual outcome. So when to do MRI? When there is an obvious sign of cerebrovisual impairment, or in patients with prematurity or seizure disorders, or if the APGAR score is low. As soon as the patient gets fitness, he should undergo an MRI. So take home message, CVI is an important cause of bilateral visual loss in early childhood, and the complete blindness is usually not there because of the neuroplasticity. The most common cause is hypoxic encephalopathy, and most common MRI finding is periventricular leukomalacia. MRI findings do have a prognostic value. They can predict the visual outcome in the individual case in the long run. These are a few references which I used for the presentation. Thank you.
Thank you, Dr. Rishikesh. It was a wonderful talk. So, in your opinion, all patients with CVI must have an MRI?
Yes, ma'am.
Must.
Actually,
Is it a must? It may not be of any prognostic value, but at least it would be of some diagnostic value.
Yeah, it does have a prognostic value. I have been managing these cases along with a neuro physician, Dr. Parimal. So he has, I keep discussing cases with him, and he says that MRI and VP should be done as early as possible, because the previous thought process was to delay them at least for 1 year or 18 months. But the earlier you do, perhaps you can predict, or it does have a prognostic value. So whenever
I
the
think
patient gets
that's,
fitness, you should
yeah,
undergo
that's the right way to go. Thank you very much. Any questions from the audience? I would like all the speakers, to come on the stage, please, for a picture.
So at the conclusion of this program, we just wanted to have one take-home message for the people in the audience. The ophthalmologists are the first point of contact for any child with visual impairment. So when the complaints of the child and the complaint that the parents have are not matching with our findings, then we have to keep CVI in mind. Any child with even minimal disability, please anticipate vision problems. Having a visual skill questionnaire handy is very simple and easy way to manage these children. We have to talk to them about early intervention, therapy, and overall development. And please do not say that nothing can be done. Once that nothing can be done is imprinted in their brain, it's very difficult to get that idea out of their head that something can be done for these children. Thank you all.